If by breath alone I can be a bigger man, how ephemeral. All right, back to our old friends Galen and Da Vinci. So Galen believed that, keep in mind that the Romans thought there were four elements, right? There was earth, air, fire, and water. And that everything was made up of some combination, some complex combination in various proportions of these things. And so there was certainly a fire element in humans, which is what was responsible for generating the innate heat that humans seem to have. And the lungs, however, were responsible for introducing coolness of air, the coolness, the ephemerality of air to temper that heat, and passing that coolness from the lungs into the heart, which they believed to be the center of the heat. And so not just into the heart, but into the left side of the heart. So they recognized this, the pulmonary veins, the large pulmonary veins emanating from the lungs and passing into the left ventricles. This was Galen. And then Leonardo's Da Vinci sort of gives us a more evocative description of the material of the lungs. He says the substance of the lungs is dilatatable and extensible, like the tinder made from a fungus, but it is spongy, and if you press it, it yields to the force which compresses it. If the force is removed, it increases again to its original size. So here he's getting at the fact that lung material is a little bit compressible and extensible, and is spongy. Has a lot of negative space in it, air space in it. It was until much later with Harvey and his lectures on the whole anatomy that it was recognized that lungs provide some sort of nourishment to the body through the blood. So the body is clearly going through a lot of effort to supply the lungs with blood that is then being distributed throughout the body. And he believed that this was some sort of nourishment, saying life and respiration are complementary. There's nothing living which does not breathe, nor anything breathing which does not live. They understood at the time, he understood this notion of respiration being essential to life. You can cut a kidney out, you can hack a bunch of somebody's intestines out in a battle, etc. But if you lose your lungs, you're in trouble. So modern pulmonology originally began as this discipline called physiology, P-H-T-H. Look at that. Look at that consonant blend there. P-H-T-H-I-S-I-O-L-O-G-Y. Physiology is a study of tuberculosis. And this was established by this guy, William Osler, who is one of the titans of modern medicine. It really was the massive struggle with consumption in Europe and the United States, which led to the growth of modern pulmonology. In the early 20th century, poliomyelitis was a massive epidemic. And this was not actually a problem of the lungs themselves, but it was a deinnervation of the phrenic nerve and the diaphragm. And so these people were unable to breathe any longer. It was crushing. These people died in droves. And it was the advent of this iron lung that was produced by a company, Drinker and Shaw, in the 20s that saved a tremendous number of people's lives. You can see up here in the right-hand corner, this was the first iron lung. So what happened here is these people were stuck in these negative pressure chambers, and there would be a vacuum pump would be applied, and that would expand the volume of the chest, and then they would have a positive pressure and would compress the chest. So they just physically pumped these people's bodies, enabling air to pass in and out of their lungs. Can you imagine this? Look at this. A whole ward of people laid out in these things. This was less than 100 years ago. There are people alive who may have seen this. So we've come quite a long ways since the polio vaccine. Yeah.
I guess, sort of side engineering question, why did they come up with this, if you know, why did they come up with this before something like hooked up to their face where there's a pump pumping air into their lungs and sucking air out rather than operating on the outside of the body?
Mm-hmm. I can't actually answer that one. I don't know. Yeah, that's there's probably some sort of engineering answer to that that I can't give you. I have to think about that. Yeah, I don't know. I don't know. So even today, yeah, I'm not sure, to tell you the truth. I mean, part of the problem is when you put a ventilation mask on a person, there is quite a lot that goes into that, right? Because the air that is moving, that needs to be properly humidified, or else you really mess up the lining, the mucosa in the nasal passages, and they may not have had the technology to do that. Perhaps they tried it. I don't know. But in this arrangement, it's not a problem because they're just breathing normal air. That's pure speculation on my part. Just having had a dad that was on one of those BiPAP machines, there's a lot of there's a lot that goes into that thing. It's not just moving air around. I don't know. Okay. Well, the name of the game here is simply getting air full of oxygen down to the surface of these alveoli so that it can exchange with carbon dioxide in the blood. These alveoli, this is the site of gas exchange. What is interesting here is the surface of the lungs, the interior surface area of the lungs. It's 35 times the surface area of your body on average. That's pretty significant. This is, I don't know, maybe I've alluded to this surface area to volume, this n and n-1 dimensional optimization. It's the ability of an theoretically infinite amount of n-1 surface to fit in a finite n-dimensional surface that guides a lot of structures in nature, but certainly within the human body. And this is one example of that. All right, so for today, I'd like to talk about the respiratory anatomy that we're going to need to have this discussion. I'll touch on asthma and COPD just a little bit, and then we'll talk about the basic physiologic process of ventilation and gas exchange. That'll set the stage for a more detailed discussion on Wednesday of hemoglobin saturation dynamics, which is, I think, the crux of respiration, my respiration lectures, and then carbon dioxide transport, and then I'll talk about lung cancer either on Wednesday, or I'll chuck it into a little video for Friday. So, all right, let's talk about the anatomy here. So there's the nasal passages and the oral cavity, which is obviously how we breathe in, either through the nose or in some cases through the mouth when we need to. Air comes in through the external nares, passes the turbinates. I have them listed there as the nasal concha. they have a few different names. The superior, middle, and inferior nasal concha or turbinates. This is the site of olfaction as well. Our sense of smell happens up here and is a result of our respiratory system. And then that air passes through the internal nares, the NARES. That's sort of our internal entry or exit from the nasal cavity. And it's right above the soft palate, between the soft palate and the pharyngeal tonsil or adenoid superiorly. Then the passage down through the pharynx, and the pharynx is this conjoined area through which both air and food pass. But we get to this boundary between the upper respiratory system and the lower respiratory system, and this is where the paths diverge. Food passes down the esophagus posteriorly, and then anteriorly we breathe through the trachea, the entrance to the trachea being the larynx. And it is this larynx, I cut out the slides that I had regarding phonation and the ability to produce sound just in the interest of time. It's not that essential of a physiological concept, but it is, of course, the larynx that produces the sounds, phonates the sounds, which then the structures of the mouth articulate into words. The trachea descends and down to the bronchioles, the primary bronchus, and the lining of that trachea protects the respiratory surfaces with this mucociliary escalator, a charming name, the mucus escalator. We'll see that in a few slides. And then there's, of course, the gas exchange, which is the principal function of the respiratory system. And the diaphragm, whose job is to move air to and off of those exchange surfaces. All right, so here is a cross-section of Jean-Luc Picard's head, and you can see these turbinates that I was referring to, and they're called turbinates or concha. You can appreciate why they're called concha, because they do have this sort of spiral pattern that you may see if you were to cut a conch shell, or turbinate as in turbine or turbulent. The goal is to create turbulence in the air that is inspired through the nose. And in so doing, it will warm and moisten the air to facilitate gas exchange on the sensitive respiratory surfaces in the lungs. It's also to trap particles that can be odorants, things that we're trying to smell. It's going to trap and dissolve them into the mucus of the nasal cavity. It's also going to stop any kind of particles that don't belong in our lungs. So it'll attach to the mucus and then eventually be expelled from the nasal cavity. All right, so here is the mucociliary elevator or escalator, whatever you want to call it. The ciliated epithelium, the ciliated columnar epithelium that lines the trachea, the larynx, the mucociliary escalator. It has these fingers, these cilia, which are coherently beating and waving all in the same direction. So there are goblet cells which are producing the mucus that lines this epithelium, and then these cilia or tendrils are all waving this mucus upward. So as things adhere to the wall of your lungs, to the trachea or the nasal cavity, these cilia are all working that mucus upward and outward. Also helps to warm the air, moisten the air with the high degree of surface area that is presented by the cilia. All right, so here's a cartoon of this same thing. We have on the right the goblet cells, these mucus cells, who are responsible for this glandular epithelium that is going to produce this mucus. And what is mucus? Mucus is an aqueous solution with a high concentration of mucins, and mucins are mucopolysaccharides. They are a type of heteropolymeric polysaccharide that is going to be very difficult to dehydrate. So mucus helps hydrate whatever surface it's on, and it's a little bit slippery too. It lubricates the surface of the respiratory epithelium. And then this is right next to these ciliated columnar epithelia with the cilia that are all coherently beating in the same direction. On the left, we see this cartoon that shows lumps of smudge. Who knows what those little brown dots represent, but they're stuff that you definitely don't want in your lungs. They are adhered to the mucus in the pharynx or in the trachea or the larynx, and it's all being moved upward and outward by this mucus elevator. What a charming term. All right. Continuing our descent towards the lungs, looking at a cross-section of the trachea, we can see these rings, these tracheal cartilages. And the tracheal cartilages are made of hyaline cartilage, and then which are lined on the inside with a layer of mucosa. So there's going to be the connective tissue, lamina propria, and then the ciliated epithelium on top of that. These cartilages are not fully concentric. Not fully annular. They don't close all the way around. You can see in this bottom picture on the left that there is a gap in the back of that is then bridged by the trachealis muscle. And that trachealis muscle can either contract or relax to vary the aperture of the trachea, can vary the diameter of that opening. So the trachea descends to this point of the carina. Yeah.
Sorry, one continuous muscle going down the entire trachea, or is there a small segment for each
band? It is a strip of, it's a muscle strip which is going to have different motor units controlling different segments of it, but it's a continuous strip that runs down the length of the trachea. So the carina is this cartilage that's at the bifurcation of the trachea into the two primary bronchi, the right and left primary bronchi. Those primary bronchi then enter what's called the root of the lung. The other word we use for that is the hilum. I think I have a picture in a moment here that will show that term, hilum, H-I-L-U-M. The hilum or root of the lung is where root of the lung, I think, explicitly refers to just the primary bronchus where that enters the lung, and hilum refers to the root of the lung plus all the vessels. So there's a tremendous number of, the bronchial arteries and veins, the pulmonary arteries and veins are all going into the lung along with the primary bronchi, and all of that forms what's called the hilum. It is at the hilum. We'll see in a moment. I'll save that thought. All right, so here's the tracheal epithelium. Not tremendously different from the epithelium in the pharynx. You can see in pretty stunning detail in this electron micrograph the goblet cells whose job it is to release this mucus, and there are deeper embedded mucus glands that you can see down in the lamina propria as well. All right, so before I jump into the functions of the lungs, I'll just show you here what this hilum looks like. So here is the root of the lung, and then here are the pulmonary arteries and pulmonary veins. All of this is surrounded by this cut edge of serous membrane. That is where the parietal pleura, the pleura of the wall of the pleural cavity, meets the visceral pleura, so that serous membrane that's lying right on the lung itself. Those two leaves of serous membrane are contiguous and meet at the hilum of the lung. This is not showing the bronchial arteries and veins. So the pulmonary arteries and veins, I'll say, are there to bring deoxy blood to the lungs to get oxygenated and then carry it back to the left atrium. The bronchial arteries and veins, their job, the bronchial arteries are bringing oxygenated blood to the lungs to serve the tissues of the lungs as well. So whatever smooth muscle and other structures that support the bronchioles are being served by the bronchial arteries, and then the deoxy blood is leaving via the bronchial veins. So what does the lung do? Obviously, if I were to ask anyone, even my 5-year-old daughter, what they do, well, they help you breathe. This is where we get oxygen into our bodies. It's the site of gas exchange is a little bit more accurate way of saying that. So not only are we inhaling oxygen, absorbing oxygen, but we are unloading carbon dioxide. The process of unloading carbon dioxide is how we are able to maintain our acid-base balance, to maintain the pH in our body. To a certain extent, we are blowing off carbon dioxide, which is helping to maintain that acid-base balance. The lungs do help us defend against pathogens. So any of the surfaces of your body that are exposed in one way or the other to the outside world, this includes your skin, the mucous membranes of your mouth and nose, nasal passage, pharynx, lungs, and even your GI tract is, in a certain sense, exposed to the external world, are going to be important in helping defend against pathogens, because they're the first line of defense, right? Those are the points of contact. So it does this through helping us to isolate inhaled particles and expel them, but it also is the site of production of a tremendous number of antibodies and the localization of eosinophils. The antibodies in particular tend to be IgE. It's a particular isotype that is associated with the eosinophils. So the lungs are a tremendous blood reservoir, which shouldn't be of a great surprise. 20% of the total blood volume at any one given time is in the lungs. But a lesser appreciated aspect of the lungs is their endocrine function. It's where we activate angiotensin, which is related to blood pressure. It's the site of catabolism of epinephrine. We break down both epinephrine and serotonin in the lungs. various leukotrienes are synthesized there as well. All right. So looking at the respiratory arborization, we see that there is a primary bronchus which then branches into the secondary bronchi, and bronchus singular, bronchi plural, and then the next, it's just like a river. We have primary, secondary, tertiary. These tertiary bronchi are smaller still. It's the next bifurcation, and we get, after tertiary, we continue to have branching until we get down to these bronchioles. There are then terminal bronchioles, which translate into respiratory bronchioles at the very bottom. And a respiratory bronchiole is a bronchiole that has a few alveoli branching off of it. So there is some actual gas exchange happening in a respiratory bronchiole, albeit a small amount. These respiratory bronchiole then become alveolar ducts, which are passageways that are lined with the alveoli, these little bubbles, and then they terminate in an alveolar sac at the very end, which is a cluster of all of these alveoli at the end of an alveolar duct. These intermediate tertiary and smaller bronchi is where you're getting significant source of ventilatory resistance to airflow, and the autonomic nervous system is going to be important. Both the sympathetic and parasympathetic nervous system is going to be important in terms of mediating the bronchodilation or bronchoconstriction of these intermediate bronchi. So we talked a little bit in the last unit about, for example, beta-2 receptors that are sympathetic receptors that will synapse on the smooth muscle in the bronchi that will then dilate. They're dilatory on the bronchioles there. So bronchodilation is mediated by the sympathetic nervous system, and bronchoconstriction from the parasympathetic ANS. All right. A little bit of pathology. Bronchitis. So bronchitis is just an inflammation of the bronchial walls, and I would be surprised if there was a person in the class who hadn't had bronchitis at some point in their life. It is a common consequence of a lower respiratory infection, having a cough or something like that. However, you can have chronic bronchitis. We call this chronic occlusive pulmonary disease. And in the United States, approximately 10 million people have COPD. And about 40,000 of those people die explicitly from COPD per year. Why do 10 million people have COPD in the United States?
Smoking.
Yeah, smoking. This is smoking. This is one of the many costs that cigarettes impose on our society. Asthma. So asthma is a chronic atopic inflammation of the bronchial walls. Atopic meaning allergic. There is there's a suite of different atopic diseases. These include atopic dermatitis, atopic rhinitis. So atopic dermatitis, commonly known as eczema. Atopic rhinitis, commonly known as what? Hay fever. But there are atopic processes that happen on the mucosa, on the conjunctiva of the eye, in the intestinal lumen. What do all these places have in common? the lungs, the skin, the intestines.
Didn't they all have epithelial tissue?
Yeah, that is open to the outside world, right? I've already said that today. So this is like the first line of defense. And what is happening in... have you guys heard of the story of that guy who had really acute asthma? And he went to Africa, walked around in a latrine, got himself hookworm, and it sent his asthma into remission. The point being here that atopic disease is an aberrant immune response mediated by what are called Th2 cells, helper T cells, helper T2 cells. This T cell population is responsible for helping mount a response to parasites. So Th1 cells help you defend against viruses and bacteria, and Th2 cells help you defend against parasites. But in the Western world, we don't really have a problem with parasites any longer, do we? And so our immune system is a little bit naive. That part of our immune system is naive in that regard. It's kind of like in World War II, these air defense guys down in the south of the island in England were waiting for the German airplanes to come over, and they'd ring the alarm when any plane would fly over because they didn't know they hadn't had a flyover yet, right? But as soon as the Luftwaffe flew over England, they learned, and they did not have false alarms. It's kind of like that. That's an analogy I use sometimes, I guess. So this atopic disease is mediated by Th2 cells. It's asthma. People with asthma have what's called eosinophilia. There's this infiltration into the peripheral blood mononucleocytes in the lungs of a lot of eosinophils, and then their IgE titers tend to go quite high. So, for example, for you people sitting here, if you're not an allergic person, maybe you have anywhere from 10 to 100 per milliliter titer, whereas a person with asthma may have as high as 30, 50,000. So it can be quite high. It's a chronic inflammation of the bronchial epithelium, and one of the ways they deal with it, it's treating a symptom, not the cause of the problem, is to give people these inhalers, this albuterol. Albuterol is a beta-2 agonist, so we learned about the beta-2 receptor the other day in the cardiac chapter when we were talking about vasodilation in smooth muscle in skeletal muscle capillaries. But it also works in the lungs here, albuterol in the corner. All right. So as I've already kind of indicated, there is 2 complete sets of vasculature going to the lungs. There is the pulmonary vasculature, the pulmonary artery and vein here. The pulmonary artery is in blue because it's deoxy blood coming from the right ventricle, and the pulmonary vein on the left down there in red because it's now oxygenated, but it's a vein because it's going back to the heart, to the left ventricle, to the left atrium. But if you look along the top margin there of the bronchiole, you'll see a bronchial artery in red and a bronchial vein in blue. So the structures of the lung, the smooth muscle of the lung, needs to get blood supply as well, and it is achieved through these bronchial vasculature, the bronchial vasculature. This is a pretty good picture to see. Walk out from behind my thing here. Keep my microphone towards me. We have a respiratory bronchiole here. So it's still a bronchiole, but it has a few of these alveoli coming off of it. And then this respiratory bronchiole descends into an alveolar duct. Right here is the ductwork with many more of these alveoli off it until we get into this alveolar sac at the end with several alveoli ballooned all around it. That is the principal site of air exchange. So the blood pressure in the lungs is low compared to the rest of the body. That the mean pressure is around 30 millimeters of mercury, and that is roughly half of what should be the lowest of the diastolic range that a person should have. So that's quite low. And because of that, because it's such a low pressure, it's an area of low resistance, you can get all kinds of stuff lodged in there. You can get fat globules, clots of blood, emboli, air bubbles, etc. This causes what are called pulmonary embolisms, which can be quite deadly. And this diagram at the bottom is showing a few emboli. I am certainly not a radiologist, so I can't, I don't know if I'd have been able to pick it out, but apparently these hypodense regions here are indicative of this business, and this business here are indicative of some emboli in the pulmonary vasculature. All right, so this is some histology here of an alveolar duct. You can see all of these alveoli branching off of it, descending towards an alveolar sac, and then a little bit of a close-up in this EM on the right-hand side. Yeah, just a nice picture. I don't really have another point to make. All right. So a cartoon looking at the different cell types that we're going to find in the alveoli. There are these pneumocyte type 1 cells, and that's depicted in purple here. The bulk of the cells are these pneumocyte type 1, and they're simple squamous epithelial cells. They are forming the bulk of the respiratory epithelium. It is across this surface that oxygen is going to exchange. Then there are these septal cells, these pneumocyte type 2, and their job is to produce a surfactant. I'll have a diagram showing surfactant in the next slide. But surfactant is an oily secretion that is made up of phospholipids and various proteins. The point here is to reduce surface tension. Why do you think that's important? What do you think, Jacob?
You gotta have gas exchange, so if there's a film on it, the gas is not going to be in contact with the epithelial cells.
That's right. So if you have epithelium here and your blood vessel down here, and you have a big water bubble right there because of the high surface tension, then the oxygen is not going to be able to get in here. So the surfactant just takes this and breaks that up, so we have a much easier surface for the diffusion of gas. And here's a picture of the pulmonary surfactant. What do I want to make a point of here? So in some babies, preterm babies, if they come out really early, this is before they're able to produce the appropriate kind of surfactant. And what they will do is provide bovine surfactant, bovine-derived surfactant to these babies to help their respiratory epithelium function properly, so it doesn't entirely fill with fluid. Yeah, I guess that's the only real takeaway from this slide. That was one of Andrea's. So there are 3 layers to this respiratory membrane. So if we look down at, zoom in on it, we can see there's going to be the alveolar epithelium, these pneumocyte type 1 cells, and then there's going to be some sort of a basement membrane, some sort of connective tissue basement membrane, just the basic connective tissue glue that is going to keep that pneumocyte type 1 cell adhered to a capillary epithelium. So those 3 layers, that capillary epithelium, the basement membrane, and the pneumocyte type 1 cell, the 3 of them together are less than half a micrometer. Less than half a micrometer. Just to give you a sense of that, that is 2/100,000ths of an inch. That it is an incredibly thin surface. This is quite delicate tissue, in fact. It is this narrowness which allows gas exchange to be so rapid across the surface. All right, so there are 3 basic steps in respiration. There's the pulmonary ventilation, the inhalation of air, and then there is gas exchange at the respiratory epithelium, the diffusion of gas into the blood, and then finally transport. So the oxygen is picked up by the hemoglobin, and CO2 is released by the blood into the airspace of the lungs. And then after these 3 processes of external respiration, then we move into internal respiration. So internal respiration is how we're using that oxygen in the tissues, how we are producing the carbon dioxide in those tissues. So external respiration, when we use the word respiration, it can be a little bit ambiguous, and we're being specific here. External respiration is ventilation, gas exchange, and then transport. And then internal respiration is what the cell is doing, the internal respiration of the cell. We're going to talk about internal respiration a little bit more in the GI chapter, and you guys are going to address it in your lectures to a certain extent. The insulin receptor and AMPK. So if your external respiration is abnormal, it can obviously be dangerous. Hypoxia is, so just a few definitions. Hypoxia is when you have low tissue oxygen levels. Anoxia is a complete lack of oxygen in the tissue. And then apnea is a interruption in breathing, in natural, in your normal breathing, and this can happen at night, most commonly for people when they have sleep-induced apnea that goes along with snoring. Sometimes people's breath, maybe you've seen them, they're like, right, so that's sort of what apnea is like. Boyle's law. Yeah, all right. So Boyle's law is is extracted from the ideal gas law. It is when temperature and number of moles of gas are held constant, but the pressure and the volume are able to change. And it's really Boyle's law which is most relevant to ventilation. Right? So if you decrease the volume in something, the pressure is going to rise. And if you increase the volume, the pressure falls. So here on the right we have Han and Luke and Leia, in a container whose volume is getting smaller and the pressure is clearly rising on them. And whereas Luke here is on his home planet and very large volume, seemingly quite low pressure on the young lad. We'll see how this plays out here. So during inspiration or inhalation on the left-hand side, the volume of the lung goes up. The diaphragm contracts and pulls the lung, the thoracic cavity downward, expanding that chamber and increasing the volume, thus decreasing the pressure in the lungs. As you decrease the pressure relative to atmospheric pressure, air is going to rush in to the lungs. And then during exhalation, we are going to contract the space. We're going to make the volume smaller, thus increasing the pressure relative to atmospheric pressure and pushing air out of the lungs. Quite straightforward, I think. I show this picture on the left just to show, this is sort of my yoga instructor coming out a bit here, that it's not just the diaphragm, the thoracic diaphragm, but it is abdominal support and the pelvic diaphragm, that abdominal pelvic boundary that helps in breathing and in the ventilation process. I think we'll leave it there. That's really all I wanted to get to today anyways.